All right, time to dive in. Welcome back, everyone, for another deep dive. Today we're going to be focusing on the thorax and lungs. And as always, we're going to be looking at this from a nursing perspective.
Absolutely. This is definitely a foundational topic for nursing students and really for any healthcare professional who wants to be able to assess patients thoroughly.
I mean, you can't really understand the respiratory system without understanding the anatomy of the thorax, right?
Yeah, the thorax is like the framework that holds everything together. It protects the heart and lungs.
It's like a fortress for those vital organs.
Exactly. And it's not just about protection either. The thorax is also designed to allow for movement so that we can breathe.
Ah, so it's strong and flexible at the same time. Kind of reminds me of a suit of armor, you know?
Yeah, I like that analogy. It's protective but also allows for full range of motion.
Okay, so let's get into the nitty-gritty of the anatomy. Can you give us a tour of the thorax? Like, what are the key landmarks we need to know?
Okay, so picture this. You've got the sternum in the front, which is like a shield-shaped bone, and then you've got the ribs, which curve around the sides like protective bars.
Like a cage, almost.
Yeah, exactly. A protective cage for the heart and lungs. And at the bottom of this cage, you've got the diaphragm, which is a large dome-shaped muscle.
The diaphragm's like the floor of the thorax.
Right. And it's a really important muscle for breathing because it contracts and relaxes to change the volume of the chest cavity.
So when the diaphragm contracts, it pulls downward and creates more space for the lungs to expand.
Exactly. And when it relaxes, it moves upward and helps push air out of the lungs.
It's amazing how everything works together so seamlessly. Okay, so we've got the sternum, ribs, and diaphragm. Are there any other bony landmarks we need to know?
Well, each rib has a space beneath it. So we have the intercostal spaces.
Oh, right. The spaces between the ribs. They're important for, locating things on the chest, right?
Yeah, absolutely. We can't just say, oh, the patient has pain on the left side of their chest. We need to be specific about where that pain is in relation to the ribs and intercostal spaces.
That's a map of the chest.
Exactly. And speaking of maps, there are some key landmarks that help us navigate the thorax.
Like what? What are those landmarks?
One really important landmark is the sternal angle. It's where the manubrium, the top part of the sternum, meets the body of the sternum.
Kind of like a little bump on the sternum.
Yeah, you can actually feel it if you run your fingers down the middle of your chest. The sternal angle is important because it marks the level of the second rib.
So from there you can count down to locate the other ribs.
Exactly. It makes it much easier to pinpoint findings on the chest.
That's a great tip. What about those lower ribs? They always seem so close together.
Yeah, those can be a little trickier to count, but you can use the 12th rib as a guide. You can feel it in the back.
Oh, right, because the 12th rib doesn't attach to the sternum in the front.
Exactly. It's what we call a floating rib.
So you can feel the 12th rib in the back and then count up from there.
Precisely. And it's also important to remember that when we're examining a female patient, we might need to gently lift the breast tissue to palpate the ribs accurately.
No, that's a good point. We want to be respectful of our patient's privacy while also ensuring a thorough assessment.
Exactly. It's all about finding that balance.
Okay, so we've talked about the bony landmarks of the thorax, but I also remember reading about something called the triangle of safety. Sounds kind of mysterious. What is that exactly?
So the triangle of safety isn't really a triangle. It's just a safe zone for chest tube insertion.
Oh, that makes more sense. So where's this safe zone located?
It's bordered by the anterior border of the latissimus dorsi muscle posteriorly.
That's the large muscle in the back.
Right. And then the lateral border of the pectoralis major muscle anteriorly.
That's the chest muscle.
Correct. And the nipple line inferiorly, which is about the level of the fifth intercostal space.
So it's basically a triangular-shaped area on the lateral chest wall.
Yeah, it's a safe zone because it avoids major blood vessels and nerves.
That makes sense. Okay, so we've mapped out the terrain of the thorax. Now let's journey into the lungs themselves.
Sounds like a plan.
Can you help us visualize those lobes and how they fit within this bony cage?
Okay, so picture this. You have two lungs, one on each side. They're kind of cone-shaped, with the top, called the apex, peeking out above the clavicle.
The clavicle is the collarbone.
Yep. And then the lung tissue extends down following the curve of the ribs. Now, the right lung has 3 lobes, an upper lobe, a middle lobe, and a lower lobe.
And the left lung only has 2, right?
Right. It has an upper lobe and a lower lobe, but no middle lobe.
That's to make room for the heart, I bet.
Exactly. The heart takes up some space on the left side of the chest.
It's like a little game of Tetris trying to fit all those organs in there. So we've got the lobes all figured out. But tell me, why is it clinically significant that the right main bronchus is more vertical?
Ooh, that's a good question. So the right main bronchus is the airway that leads to the right lung. And because it's more vertical, it's a more direct path for things to get into the right lung.
Things like
Well, unfortunately, things like aspirated material,
aspirated material being.
like if someone accidentally inhales food or liquid, or if they vomit and some of it gets into their lungs.
Oh, yuck. So because the right main bronchus is more straight up and down, aspirated material is more likely to end up in the right lung.
Exactly. And that's why aspiration pneumonia is more common in the right lung.
Ah, that makes sense. So knowing our anatomy helps us anticipate potential problems.
Precisely.
This is so interesting. Okay, I have to ask about the pleurae. They always sound so mysterious to me.
They do have a certain mystique about them.
Can you demystify them for us? What are they and what do they do?
All right, so the pleurae are basically two thin, slippery sheets of tissue. You've got the visceral pleura, which is like saran wrap around the lungs. It covers the entire surface of each lung.
Okay, so it's like a protective layer.
Exactly. And then you've got the parietal pleura, which lines the inside of the chest wall.
So it's like the lining of the thoracic cavity.
Right. And between these two layers is the pleural space.
Which is
Well, potential space, really. It normally just contains a tiny amount of fluid.
Okay, so what's the point of this pleural space?
Well, that fluid acts like a lubricant. It allows the two layers of pleura to slide smoothly against each other during breathing.
Ah, so that's why the lungs can expand and contract without friction.
Exactly. It's a pretty ingenious system.
It really is.
Yeah,
But I'm guessing this is where things can go wrong with pleural effusions.
you're catching on quick.
Ah,
Yes, a pleural effusion is when there's an abnormal buildup of fluid in that pleural space.
and that extra fluid can compress the lung, making it hard to breathe.
Exactly. It's like trying to inflate a balloon inside a water bottle.
Ouch. That doesn't sound fun at all. Okay, so we've covered the thorax, the lungs, and the pleurae. Before we move on to the actual exam, can we do a super quick review of how breathing works?
Sure, it's all about pressure changes, really. When you inhale, the diaphragm contracts and flattens out.
Creating more space in the chest cavity.
Right. And that decreases the pressure inside the chest. So air rushes in from the outside to equalize the pressure.
Because air always flows from high pressure to low pressure.
Exactly. And then when you exhale, the diaphragm relaxes and moves upward. The pressure inside the chest increases and air flows out of the lungs.
It's amazing how our bodies do this automatically without us even having to think about it. And it's also amazing how much we can learn about a patient's respiratory health just by observing their breathing.
Right. Things like their respiratory rate, their breathing pattern, the effort they're using to breathe. All of these can give us clues about what might be going on.
So even before we touch the patient, we're already gathering information.
Exactly. Observation is a crucial part of the pulmonary exam.
Okay, so we've laid the groundwork with the anatomy and physiology of the thorax and lungs. Now let's move on to the fun part, the actual hands-on assessment. What are the key techniques we use to examine the thorax and lungs?
There are four main techniques: inspection, palpation, percussion, and auscultation.
Okay, I'm ready to dive into those.
Great. Let's start with inspection. This is where we use our eyes to carefully observe the patient's chest.
What are we looking for exactly?
Well, first we look at the overall shape and symmetry of the chest.
So is it round, barrel-shaped, or both sides symmetrical?
Exactly. And we also look for any deformities, asymmetry, or unusual markings on the skin.
Like scars, for example.
Right, or any signs of trauma. And we also look for signs of respiratory distress.
Like what kind of signs?
Well, are they using their accessory muscles to breathe? Are their nostrils flaring? Is their breathing pattern normal? Or is it labored or irregular?
So we're basically looking for anything out of the ordinary.
Exactly. Any subtle hints that might point us towards a problem.
Okay, inspection makes sense. Now what about palpation?
Palpation is where we use our hands to feel the chest.
What kind of things can we feel for?
We can check for things like tenderness, masses, or any unusual crepitus.
Crepitus, what's that?
It's a crackling sensation you can sometimes feel under the skin. It can indicate air leaking into the tissues.
Well, that doesn't sound good.
Right. And we also assess chest expansion during palpation.
So we're feeling to see if both sides of the chest are moving equally when the patient breathes in.
Exactly. And we're also feeling for tactile fremitus.
Tactile fremitus. That one always trips me up.
Don't worry, it's not as complicated as it sounds. Tactile fremitus is just the vibration you feel on the chest wall when the patient speaks.
Really?
Yeah, you use the ball of your hand to feel for it, as the patient says, 99.
99.
Yep. It's a good word because it produces a lot of vibration, and normally tactile fremitus is symmetrical on both sides of the chest.
So if it's not symmetrical, that could be a sign of a problem.
Exactly. Certain conditions like pneumonia or a pleural effusion can change the way those vibrations travel through the chest.
Okay, that's pretty cool. So we've got inspection and palpation down. What's next? Percussion.
You got it. Percussion is where we tap on the chest wall to assess the underlying tissues.
Like we're playing a drum.
Not quite that hard, but we do use our fingers to tap and listen to the sounds that are produced.
What kind of sounds?
Well, the sounds tell us about the density of the underlying tissue. For example, a resonant sound, like tapping over a normal lung filled with air, sounds hollow.
Kind of like tapping on an empty box.
Yeah, exactly. But a dull sound, like tapping over fluid or solid tissue, is much quieter and less resonant.
More like tapping on a full water bottle.
Perfect analogy. And by listening to these percussion notes, we can get a sense of what's going on inside the chest.
So if we hear dullness over an area where we'd normally expect resonance, that could be a sign of something like pneumonia or a pleural effusion.
Right. Percussion can give us valuable clues about the underlying lung tissue.
I'm starting to feel like a detective. Okay, last but not least, we have auscultation. This is the part where we get to use our stethoscopes. What are we listening for when we auscultate the lungs?
We're listening for two main things: normal breath sounds and adventitious sounds.
Okay, what are normal breath sounds?
They're the soft, rustling sounds of air moving in and out of the lungs.
Kind of like wind blowing through the trees.
Yeah, that's a good way to describe it. And we listen for the quality of those breath sounds. Are they clear and distinct, or are they diminished or absent?
And what about those adventitious sounds? What are those?
Adventitious sounds are abnormal breath sounds. They can indicate a problem with the airways or the lung tissue.
Like what kind of problems?
Well, there are a few different types of adventitious sounds: crackles, wheezes, ronchi.
Oh yeah, I remember learning about those in class.
Each one has a distinct sound and can tell us something different about what's going on in the lungs.
So crackles sound like?
They're brief, popping sounds, often described as discontinuous.
Kind of like Velcro being pulled apart.
Exactly. Wheezes, on the other hand, are continuous musical sounds, often described as high-pitched whistling.
Like a squeaky toy.
Yep. And ronchi are lower-pitched, snoring-like sounds.
So each sound has its own unique personality. It's like a whole language of lung sounds.
It is, and it's a language that every nurse needs to learn to speak fluently.
This is all so fascinating. But before we get carried away with our auscultation adventure, are there any red flags we should be listening for? Anything that sends up a big warning signal?
Absolutely. One of the most ominous findings is a silent chest.
A silent chest. That sounds terrifying.
It is a serious finding. It means there's very little air movement, which could indicate a major problem.
Like what kind of problem?
It could indicate a severe asthma attack, a tension pneumothorax, or even a complete airway obstruction.
So if we hear a silent chest, we need to act fast.
Exactly. It's a medical emergency.
Okay, I'll definitely be on high alert for that. So we've covered the four main techniques of the pulmonary exam: inspection, palpation, percussion, and auscultation. It's like we've been given a toolkit for assessing respiratory health. But how do we put all these pieces together to make a diagnosis?
That's where the real detective work comes in. By carefully observing, palpating, percussing, and auscultating, we gather clues about what might be going on inside the chest.
It's like putting together pieces of a puzzle.
Exactly. Each finding gives us a piece of the puzzle. And when we combine them all, we start to see the bigger picture.
So to help us see how these pieces fit together, let's dive into some real-life case examples.
Let's say you're examining a patient and you immediately notice they have a barrel-shaped chest. When you listen to their lungs, the breath sounds are very quiet and they seem to be working really hard to breathe out. What would be at the top of your differential diagnosis list?
A barrel chest and quiet breath sounds. Those are both kind of classic signs of COPD, aren't they?
You're absolutely right. COPD is definitely a strong possibility in this case.
So how does COPD lead to a barrel chest?
Well, in COPD, the airways are chronically obstructed, which means it's harder for air to flow in and out of the lungs. This can cause air trapping, where air gets stuck in the lungs and can't escape. And over time, this air trapping can actually change the shape of the chest, making it more barrel-shaped.
Ah, so the lungs are chronically overinflated, like a balloon that's been blown up too much.
Exactly. And the quiet breath sounds you mentioned, that's also consistent with COPD. because there's less air moving in and out of the lungs due to those obstructed airways.
So the breath sounds are diminished because there's just not as much airflow to create those sounds.
Precisely. And you also mentioned that the patient was working hard to exhale.
Yeah, they seem to be really putting in a lot of effort.
That's another classic sign of obstructive lung disease. It's like trying to blow air out of a straw that's been pinched almost shut.
It takes a lot more effort to get the air out.
Exactly. So in COPD, the expiratory phase of breathing is prolonged because it takes longer for air to escape through those narrowed airways.
This is really helping me understand how all these pieces fit together.
Okay, give us another case. I'm ready to put on my detective hat again.
All right, picture this. You're examining a patient who comes in complaining of fever, cough, and chest pain. When you examine them, you find that a specific area of their chest sounds dull when you percuss it. And you also notice that tactile fremitus, remember those vibrations we feel when the patient speaks, is increased in that same area.
Oh, yeah. I remember learning about tactile fremitus. It's like feeling the sound waves through the chest.
Exactly. And in this case, it's increased, which tells us something interesting. You also hear bronchial breath sounds in that area where you wouldn't normally expect them.
Okay, let's see if I can piece those clues together. Dullness to percussion means there's something dense in that area, right? Like fluid or consolidation.
You got it.
And increased fremitus suggests that sound is traveling better through that denser area. And bronchial breath sounds where they shouldn't be.
Oh, this makes me think of pneumonia.
You nailed it again. Pneumonia is a very strong possibility in this case.
So why do we hear dullness to percussion in pneumonia?
Well, in pneumonia, the alveoli, those tiny air sacs in the lungs, become filled with fluid and inflammatory cells. This creates a denser area that doesn't resonate as well when we percuss it.
Ah, so it's like the pneumonia is replacing the air in the lungs with something denser.
Exactly. And that denser material also transmits sound more effectively, which explains the increased tactile fremitus.
So it's almost like the pneumonia is creating a pathway for sound to travel through.
Right, and the bronchial breath sounds we hear are another clue that supports the diagnosis of pneumonia.
Why is that?
Normally, we hear bronchial breath sounds over the trachea, where the air is moving quickly and turbulently. But when there's consolidation in the lung, like in pneumonia, the sound waves travel more easily through that denser tissue. So we hear those bronchial breath sounds in areas where we'd normally hear vesicular breath sounds.
Okay, that makes sense. It's like the pneumonia is changing the acoustics of the lungs.
Exactly.
Okay, one more case. Hit me with your best shot.
All right, challenge accepted. Let's say you're examining a patient, and as they're breathing, you notice that one side of their chest isn't expanding as much as the other.
Unilateral chest expansion lag, right?
You got it.
And you also notice decreased breath sounds on that same side.
What's your first thought?
Well, unilateral chest expansion lag and decreased breath sounds on one side. That makes me think of something that's compressing the lung, preventing it from fully inflating.
Good thinking.
And because it's only on one side, I'm wondering if it could be something in the pleural space.
You're on the right track. What could be in the pleural space that would cause those findings?
A pleural effusion.
Bingo. That's definitely a strong possibility.
So the fluid in the pleural space is pushing on the lung and preventing it from expanding fully.
Exactly. And that's why we see the decreased chest expansion on that side.
And the decreased breath sounds are because...
the fluid is also muffling the breath sounds, making them quieter on that side.
Okay, that makes sense. Wow, these case examples are really bringing it all together for me. It's amazing how we can use these simple techniques to uncover so much information about what's happening inside the lungs.
That's pretty incredible, isn't it?
It's like we're solving mysteries.
Exactly. And the more we practice these techniques, the better we'll become at recognizing patterns and making those connections.
So what are some key takeaways from all of this for our future nurses out there?
Well, I think the most important takeaway is that a thorough and systematic approach to assessment is essential. We can't just rely on one finding or one test. We need to use all the tools in our toolkit: inspection, palpation, percussion, and auscultation to get a complete picture of what's going on.
And we need to remember that anatomy and physiology are the foundation for everything.
Absolutely. Understanding how the respiratory system works is crucial for interpreting our findings.
And it's also important to remember that every patient is unique.
Right. What might be normal for one person might be abnormal for another.
So we need to consider the patient's individual circumstances when we're assessing them.
Exactly. And we should never hesitate to ask for help if we're unsure about something.
There's no shame in consulting with a more experienced nurse or a physician.
Right. We're all here to learn and grow.
And to provide the best possible care for our patients.
Couldn't have said it better myself.
This deep dive has been so helpful. I feel like I have a much better grasp on the thorax and lungs now. But before we wrap things up, I know there was some really important information in the source material about health promotion.
Oh, yeah. We can't forget about that.
Let's talk about that in our next segment. Okay, so let's jump into health promotion related to the thorax and lungs. What are some key things we should be thinking about as future nurses?
Well, lung cancer screening is a big one. We know that lung cancer is a leading cause of cancer death.
Yeah, it's a really serious issue.
But the good news is that early detection can make a huge difference in outcomes. So we need to be talking to our patients about their smoking history.
And if they've ever smoked, we should be asking how much they smoked and for how long.
Exactly. And then we can use that information to determine if they're eligible for lung cancer screening.
So who should be screened? What are the guidelines?
Current guidelines recommend annual screening with low-dose CT scans for adults aged 55 to 80 who have a history of heavy smoking.
Heavy smoking beam.
At least a pack a day for 30 years or more.
Wow, that's a lot of smoking.
It is. And even if someone has quit smoking, they might still be eligible for screening if they quit within the past 15 years.
So it's really important to get a detailed smoking history from our patients.
Absolutely.
Okay, lung cancer screening is definitely a top priority. What other lung-related health promotion topics should we be thinking about?
Well, another one that's really important is latent tuberculosis infection.
Latent TB.
Right. Remember, people with latent TB don't have any symptoms and they're not contagious.
So they might not even know they have it.
Exactly. But they could develop active TB later on if the infection isn't treated.
Oh, wow. So it's kind of like a ticking time bomb.
In a way, yes. That's why screening is so important. It allows us to identify those individuals who have latent TB and get them the treatment they need to prevent active disease.
So how do we screen for latent TB?
We have a skin test and a blood test.
And which one is better?
It really depends on the individual patient and the setting.
Ah, okay.
Yeah.
So we need to use our clinical judgment.
Exactly.
And if someone tests positive for latent TB, what happens then?
They'll need treatment to prevent the infection from progressing to active TB. The good news is that latent TB is much easier to treat than active TB.
So early detection is key.
Absolutely.
Okay, we've covered lung cancer screening and latent TB screening. Any other big ones we should have on our radar?
One more that's becoming increasingly important is obstructive sleep apnea.
Oh, yeah. Sleep apnea. I've heard that snoring can be a sign.
Snoring can be a clue, but it's not the only one. People with sleep apnea might also experience excessive daytime sleepiness, morning headaches, or they might even wake up gasping for air.
That sounds really scary. And I know untreated sleep apnea can have some serious health consequences, right?
Right. It's been linked to high blood pressure, heart disease, stroke, and even diabetes.
Wow, so it's not something to take lightly. How do we know if someone needs to be evaluated for sleep apnea?
There are questionnaires we can use to assess risk, like the Stopping questionnaire.
Stoppy bang. What does that stand for?
It stands for snoring, tiredness, observed apnea, high blood pressure, body mass index, age, neck circumference, and gender.
So it covers a lot of bases.
It does. And if someone has symptoms or is at high risk based on the questionnaire, they'll likely need a sleep study to confirm the diagnosis.
A sleep study.
Yeah, it's a test that monitors their breathing and other vital signs while they sleep.
Okay, that makes sense. And of course, we can't talk about lung health without mentioning the elephant in the room, smoking.
You're absolutely right. Smoking is the #1 risk factor for lung cancer and a whole host of other respiratory problems.
That's the worst thing you can do to your lungs.
Pretty much.
Mm-hmm.
So as nurses, we have a responsibility to talk to our patients about the dangers of smoking and to provide support and resources to help them quit.
We need to be those champions for our patients' health.
Exactly.
Wow, this has been a whirlwind tour of the thorax and lungs. We've covered so much ground, from the anatomy and physiology to the exam techniques to health promotion.
It's been a great deep dive.
It really has. So to all our future nurses out there, what are some key takeaways you want them to remember?
Well, first and foremost, I want them to remember that a thorough respiratory assessment is crucial for identifying potential problems.
We need to use all of our senses, sight, touch, and hearing to gather clues.
Exactly. And we need to be able to connect those clues to the underlying anatomy and physiology.
And we need to remember that health promotion is just as important as disease detection.
Absolutely. We have a responsibility to educate our patients and empower them to make healthy choices.
Well said. This has been such an informative and engaging deep dive.
I've enjoyed it.
Me too. And I know our listeners have learned a ton. So until next time, keep those brains buzzing and those stethoscopes handy. We'll be back soon with another deep dive into the fascinating world of healthcare.